Warm welcome to the final session of this conference, Trust-Wide Learning, Staff and Patient Experience as the Driving Force Behind Improvement. My name's Tim Horton. I'm an Associate Director at the Health Foundation, and I'm going to be your chair for this session today. A couple of years ago at the Health Foundation, we produced a report called the Improvement Journey, which looked at the importance of organisation-wide approaches to quality improvement. By organisation-wide approaches, I mean an approach that aims to embed a culture of continuous improvement and learning across a trust, along with the strategy and skills and capabilities to make it a reality. And we looked at the importance of organisation-wide approaches to improvement in making sustained improvements to the quality of care within trusts, as well as the challenges of putting them in place. And in this session, we're going to be joined by people from two trusts at different stages in their improvement journey to reflect on their experiences and what they wish they'd known when they started out. And to do that, I'm thrilled to be joined by Sir Jim Mackey, Chief Executive of Northumbria Healthcare Foundation Trust, and Elizabeth Hale, Director of Improvement at Central London Community Healthcare Trust. So a very warm welcome and thank you to both of you for joining us today to share your experiences. I'm particularly excited to be at this event today because this month sees the launch of a new programme that NHS providers are running, supported by the Health Foundation, which aims to support trust boards to embed a trust-wide approach to quality improvement. And it's going to do that through workshops, seminars, virtual visits, basically to allow trust boards to share practical peer learning about how trust-wide approaches to improvement can be put in place and help sustain some of the gains we've seen during the pandemic. And it will also help trust boards navigate some of the resources that are available to support them on their improvement journey. So it's really good that we're having this session today. Do look out for more about that programme. You'll be able to sign up for some of the seminars and sessions via the links you'll see in the chat today. Now, before I hand over to our speakers, we wanted to ask you where you think your trust is on its improvement journey. So we're going to do this through a poll, which should pop up in a box. And what we're asking is, where is your trust on your improvement journey? Has it got no plans to implement an organisation-wide approach? Has it made a commitment to start doing so? Is it just underway? Or has it largely implemented an organisation-wide improvement approach? So do answer that via the box that should pop up. So I think we're getting the results in. Do fill out the poll in the box that should have popped up. So we've only had a few people vote, but as you can see, most who have said that their trust is just underway in implementing an organisation-wide approach. So that's really positive because in those trusts, you'll be grappling with many of the issues that we're going to be exploring in the session today. To do that, without further ado, I want to hand over to Sir Jim Mackey to tell us about the Northumbria experience. So thanks for joining us, Jim, and over to you.
Thanks, Tim. Next slide, please. So I'm just going to talk through for a few minutes our approach to this over many years, and then a couple of slides to just illustrate some of the key points, and then I'll wrap up at the end on the issue about what do I wish I knew at the beginning, because it's been a bit of a long journey from our perspective. Just to kick off, we started with a relationship with Kaiser back in the early 2000s, which created a lot of improvement energy. Some of it was quite hard to translate, but it produced things here that still exist today, and that was great. Our SHA at the time, just after that, kicked off the links with Seattle and the Toyota production system, and that caused a bit of confusion here. So it made it difficult for people to get their heads around how we could be connected to two systems effectively. So there's a bit of learning from us in all of that. We didn't actually formally join the Toyota process as a result. That taught us, I think, about the problems around language and definitions and very discrete and prescribed models, etc. And also, really importantly, I think going with the energy. So where people have enthusiasm and energy, really trying to go with that. We developed that into a flexible method agnostic approach, so a toolbox approach, which has its ups and downs, but generally stood us in good stead. And in 2010, built our staff experience program, which I think really gave us a lift off from an experience perspective. In 2018, sorry, the 2010 process was patient experience. 2018, we got into staff experience. I'll just show you a few slides on that, and then we'll cap off at the end. So next slide, please. And next slide. So I'm sure you've seen Michael West's statement on staff engagement trumping all other measures, and we really committed to that. That is really absolutely what we believe. So in 2019, just before we were inspected by the CQC again, we were aware that our approach wasn't as clean and easy to understand as many other organisations that had been rated outstanding. It looked a bit messy, and that helped us distill our approach really to being absolutely all about staff and patient experience. So it isn't Toyota, Six Sigma, any of the really clearly defined methods. It's a toolbox based on engagement with people. Next slide, please. And this is a sample of an infographic that we use for different sites and services, etc. It shows really importantly how staff experience measurement sits alongside patient experience measurement. We again believe very strongly on the interaction between the two, and that's really helped us over the years. And next slide, please. And at the beginning of COVID, we tweaked our approach to try and specifically listen to concerns, feelings, worries of our staff at a time of extreme pressure. And we give this a lot of thought at the beginning about what would it tell us. It might tell us things we can't deal with, all the stuff around PPE, etc. It'll give us horrible messages, etc. And there's a real process at the beginning about holding our nerve and hanging on to things that were important during extremis rather than ditching them when we're under pressure. And next slide, please. So that was originally Corona Voice. It became Northumbria Voice, which was a weekly measurement system, huge numbers of staff. You can see here the blue bars show our weekly score out of 10, so a height of 6.5 there, low point of 5.2. And the line shows COVID mortality in the organisation. We had a really tough period in January, February, where the results were very, very hard to receive. So again, a message in this is you've got to be able to receive bad messages as well as good messages. It actually proved the system was working. If it was telling us all of our staff were fantastically happy and enthusiastic during very, very difficult times, we'd be really worried about the measurement and what it was telling us. Next slide, please. So what do I wish I knew at the beginning? So just very briefly, this is really complicated, a combination of very complicated and very simple. Beware of the language, beware of the traps of over-defining the process. There's a lot of people feel very, very, very dogmatic about improvement. Our view has been all along, we have to be very flexible. We have to have a toolbox approach, and it's absolutely all about people. You have to be prepared to receive messages you don't want to receive, and often that's where most of the improvement is. So when times are tough and you're finding things that need to be improved, areas where staff and patients aren't happy, that's absolutely where the most improvement opportunity is. So it sounds obvious, but it's difficult to do, and in real life. And there is something about going with the energy, making sure you're curious, making sure there's a hunger for improvement. And don't forget, the measurement and psychology is really, really important in all these things. So we sort of knew a lot of that at the beginning, but you really find out during the process that these things are absolutely essential. And then just very finally, before I hand over, I heard Don Berwick talk about this many years ago, and he kept emphasizing you need method and purpose. And I'll never forget that. I think it's really important. Fantastic methodology without any idea what you're trying to do is not going to get you anywhere, and vice versa. So I'm happy to wrap up there and hand over to Elizabeth, if that's okay.
Thanks very much, Sir Jim. Fascinating to see, particularly the work you've done on staff voice there at Northumbria and how you're taking that forward. Just to say to everyone watching, we're going to have a session later on for panel discussion and Q&A, but we have a moment now to put some questions to Sir Jim before we move over to Elizabeth. If you have a question, please post it in the Q&A function within Zoom, and we will receive it that way. I was just going to quickly ask Jim, so obviously COVID has dramatically shaped the context, of course, over the last year. Something coming over the horizon, though, are integrated care systems, including in the bill that we'll be seeing in Parliament. And I wanted to ask, how is that changing things? How are you engaging with your partners locally? And how are you thinking about improvement at a kind of system level?
That's a really good question. Again, this will be something we're all in different places from an ICS perspective, etc. And we've got lots of work, like lots and lots of work going on in terms of recovery together, especially through our provider collaborative. For now, we did a huge amount during COVID in terms of helping each other out and supporting each other, moving staff and patients around, etc. From a critical care perspective through last year, and also just helping people out through winter in terms of general winter pressures. We've not actually had a proper conversation about sharing improvement approaches and methodologies as a distinct thing. It's been more part of how we support each other in tough times. So I'm guessing that'll be something we'll have to explore over the coming months. And with that, we'll hit the usual complex thing in this system stuff about where things are best done very locally in place, in institution, etc., versus done on a larger scale. I should have emphasized in my slides earlier on, we cover 2,500 square miles, lots of sites. There's lots of slight, important differences in culture and demographic and behavior and service mix, etc. So the approaches don't absolutely always work exactly the same in every place. And I think that is a bit of a complexity for system working as well.
Really interesting. I mean, something I know you've got at Northumbria is Rubis QI, this outfit that can work with others to help them with improvement and innovation and spreading good ideas. Do you think that's going to become a model we'll see more? I mean, when I look at the NHS, I see things like the VMI partnership program on, when, of course, the Virginia Mason Institute will be a classic example of a large provider creating an arm for that outreach. Do you think we'll see more of that?
I would hope so. I'm a really strong believer in the power of collaboratives. So through Rubis QI and other approaches, we've got some really powerful collaboratives in different themes, whether that's hip fracture or stroke or, whatever the issue is. I think there's a lot of evidence that they really work. And I think that goes back to the point about going where the energy is. If people of their own volition want to join something, you're winning 3-0 at the beginning because you've got energy, you've got motivation, you've got direction, etc. So I think collaboratives should be part of the future. I think in many ways they're regarded as part of the past, but the evidence is that the work, and should hang on to that.
Really interesting. Thank you. I'm in a second going to hand over to Elizabeth. Just to encourage everyone listening, please do post questions in the Q&A, both for Elizabeth, but also for both of our speakers for the panel discussion we'll be coming on to shortly. But without further ado, I'd like to hand over to Elizabeth, Director of Improvement at Central London Community Healthcare. Thanks, Elizabeth.
Thank you, Tim. Yes, I'm delighted to be here. And if I could just have my first slide, what I want to talk to you about today is the kind of formal journey that we've been through at CLCH, Central London Community Healthcare, with our QI journey, but also some of those things that have happened kind of under the waterline, really, are my observations about that journey and some of the things that have held us back in the past. So if I could just have the next slide. What I just want to mention very briefly, and it's really interesting hearing Jim talk and just the kind of, there's so many similarities, you think we might have planned these presentations together. Context makes such a lot of difference. So we have about 4,500 staff. We cover 11 London boroughs and work into Hertfordshire, providing just community services for adults and for children. And what we are is an incredibly dispersed organisation. So we have over 100 sites and bases that our staff work out of, but they provide healthcare in people's homes, in schools, in our clinics and in our community beds. So that makes the job of spreading QI more complicated and more complex, really, I think, because of the dispersed nature of the trust. And I'll come back to that in a moment. So if I could have the next slide. What we've got here is that lovely kind of formal arrow that gives you that really straight view of this is the timeline. So this is the kind of official version, really. So our journey started 10 years ago in 2011, and what we had was a QI evangelist enthusiast that joined the trust and was frankly a lone voice for a while until our new medical director came, Jo Medhurst, and she's hugely supportive, and that started the growth of QI in the trust and the establishment of our first training programme. I joined the trust in 2016, and at the same time we had a new chief exec, Andrew Ridley, and chair, Angela Greatley. They were very supportive of QI as well, and the QI team, the very small team, all three of them, came to me at that point as I was leading change and transformation in the trust. And what we did then was launch a QI strategy and put in place a new training programme, because we'd observed that, in fact, in the past, whilst people had been trained, there wasn't a huge amount of QI activity actually happening in the trust. And that was 5 years on. So we thought we need to do this differently. And one of the things that we did was really invest in training our managers and leaders, because we thought that that would make quite a significant difference. So board support and energy, enthusiasm for this, a new training programme and a strategy. But in 2018, I think we took a long, hard look and thought, actually, this still isn't working. We've got all of the jigsaw bits in place, but we're just not getting traction. So it was at that point that we applied for the NHS Improvement Board QI Development Programme. And in fact, Anna came to us from Trust in Northumbria and led that programme and really did a sterling job with us and got us to take a long, hard look at what was happening. Now, I'll come on to the progress that we've made, but just to say really where we are now in 2021 is we've got a much expanded QI team, and we are just now launching our first trust-wide collaborative, which is made up of 20 teams, all focusing on a Joy in Work programme, which is driven by our staff survey results. So they're all working together on how do we address those issues that are holding us back locally and will really make a difference to staff in the workplace. And so we're hugely proud of that, as well as all the local QI work that is now happening. So that is our journey. So if I could have the next slide, please. What I want to refer you to here is the very important report that Tim mentioned earlier on from the Health Foundation about the Improvement Journey. This was published at the time that our board started on our board programme. And I think we very quickly realised what we'd actually done on this journey, which goes from step 1 through to step 6, and the logic is you'd follow them in sequence, is we'd simply started at step 4. So we'd invested an awful lot of time in a strategy and lots of training, but we didn't really have all those other enablers in place, and we hadn't really lined up the board fully behind that programme. I think the really important missing bit for me, though, was in step 3. And what that step 3 talks about is building the programme in stages. And just as Jim had said, start with enthusiasts, those that are willing to do it, and then encouraging others to follow. And that really is the kind of key that I want to talk about now for that kind of other observation about our journey. So if I could just have the next slide. And what this does is it rapidly takes you through the journey of a video. So it starts out with someone who's a lone voice, and the next slide. And then that lone dancer, this slightly odd person dancing and everybody else watching, is then joined by somebody else. And this is the power of two. And you can watch this video very easily on YouTube. It's the Dancing Man video about starting a social movement. And if we can go to the next slide as well. So having had a second person up and dancing, you then get to have a few more. And this group doesn't look quite so odd and unusual at this point. And you've got the beginnings of a movement. And I would say that's what we had in the Trust when I joined in 2016. We had that beginnings of a movement, but that didn't automatically mean that things were going to really start to take off. And then if I can have the next slide. And so now we have a movement, and I think this is where we are now in the Trust. And in these slides, you'll find the link to the video. It takes 2 minutes to watch. Do watch it. It's incredibly powerful. And so what I'd just like to do now is take you through the observations of what got us to this point, what has really made the difference. And I think the first thing, obviously, is investment, the size of our team with the board level of commitment. So the team has gone from 3 to 10. They are incredibly able staff, and they are a real credit and are very creditable within the Trust. But I think it really showed that level of investment happening all at one time. It just signalled very visibly across the Trust that this is something that the board was supporting and was absolutely behind, and that was really important. The other thing is the kind of tribal recognition that within that new team, we had a number of clinicians, and that was really important. And within that, for an organisation like ours, which has got so many nurses, we had got a nursing complement as well, and that's been really important too. The other is, and it's my observation about looking at this picture actually looks like there's two little groups going on. And I think we certainly did have this. We already had an initiative in the Trust, shared governance, and we had established quality councils, and they were very powerful in having staff representation, but also patients on those councils as well. And they were all trained in QI techniques. And what we've managed to do now is bring those two teams to work seamlessly together. So if people across the Trust need support for improvement with their ideas, we can direct them to which is the best approach. And it's not seen that people have to kind of fathom, well, is this shared governance or is this QI? It's seamless and it's together now. So that's really important. Three more observations that I'd make, though, are more kind of COVID and recently related. So the first is the investment that we made in social media and comms. So as things have become more digital, our communication channels have followed suit. And we've had a lot of investment in our Twitter account and the kind of general publication of bot blogs, information that's shared right across the Trust. And that has really helped to kind of make this a visible movement across the Trust and attract people either from a periphery or bring them into the centre of that group. So the social media account's been really important. The other one is simply the uptake of digital communications because of COVID right across the Trust. Our hub, our intranet is used extensively, has been throughout COVID. And it means that we can publish those blogs, set up communities of interest, community of practice really, really easily. And so that complicated dispersed geography that we're working across from Hertfordshire right down into South London means that people can very easily connect remotely in a way that they never could before. And it means that those links and relationships are being made across the Trust. And it sort of compensates for the fact that before, those visual charts, the infographic that Jim showed, that's, I think, what we always wanted, those visual artifacts for QI that you could see around the Trust. But actually, with so many sites, it became impossible to do that, whereas now we can just share those things virtually. The last point, though, is just about COVID itself, and it is that sort of age-old observation about not wasting a good crisis, and that really in those times of crisis, what you often get is a kind of a watershed for growth. And I think that certainly happened within our own Trust. Frontline staff were enabled and really facilitated to just get on and with their own solutions. And that has unleashed a level of energy really that I have not seen in the trust before. And so our reflections now are, how do we harness that to make sure that this new culture and energy and enthusiasm around improvement generally and QI in particular is embedded. So if I can just go to my last slide now, because this is really where we are hoping to get, so that we've got literally everybody standing up, being a dancing man and part of that movement. And how we believe that's going to happen is through a programme which has been developed through a collaborative to develop QI coaches. And those coaches are frontline staff who are trained in QI tools and techniques, and that they are also trained in coaching techniques as well, and have protected time so that they can support frontline staff to take the initiative and take the ownership of QI, because it cannot be masterminded in a trust our size by a small central team, however able they are, of 10. It has to become part of the way of doing everything for all of our frontline staff. So we're hugely optimistic about that programme. We were fortunate in 2019 to gain funding from the Health Foundation for this programme. So we've been leading a Q exchange project to develop a training programme for QI coaches. And that has been developed collaboratively with 12 other organisations across the country. Throughout COVID, that work has continued. And that programme now, which has got lots of virtual tools in, is being tested. And we believe once it's been through its piloting that it will become available and really useful and widely available for trusts wanting to take up this, this mantle. So I hope that these observations will help you if you're thinking about leading a QI programme, but also about starting a social movement. So thank you. Tim, I'm sorry, I think you might still, you're on mute, Tim.
Thank you. Always happens. I was just thanking you and saying what a powerful point it was about the importance of this not being owned by an individual team, but an agenda that's collectively owned across the organisation. Let me just monopolise my position as chair to ask you the same as I did to Sir Jim. How are integrated care systems affecting your thinking around improvement? I mean, I'm struck by the diagram you showed at the beginning of just how dispersed the trust is. So, of course, you're well used to working across organisational boundaries. But how is this new agenda potentially affecting thinking?
So I think there are two things that I would point to. I think there have been lots of conversations over a long period of time, and they are being woven into the ICS planning. It's around how do we share our QI resources. So there is a growing body of people who are very experienced in this area, but also what I'm interested in is the number of staff that we've got across the trust who have got like masters in improvement science. They really like this. So it's about bringing that together. And again, the digital tools make that so much easier. But the more we can share those resources, I think, and pool them across systems, though I've not seen, because we actually work in 4 ICSs, so and Northwest London is our home one, that there are any kind of formal proposals for that at this stage. But I think informally, lots of those teams within different organisations talk a lot and share. As I say, we've the collaborative nature of the work that we've done developing this coaching programme just shows that those people with that mindset are very keen and willing to work together. The other observation I would make, though, is actually talking to frontline staff. So if I look at our community teams and the way that they are working increasingly in an integrated way, they are full of ideas about how QI can help them. And that the QI methodology is actually incredibly helpful to bring people together from different organisations to work together on a project. And that in itself is a really good way of developing the integration skills that we need.
Great, thank you. Now, we've got some questions coming in on the Q&A. Do let me repeat my encouragement to people to post questions, because we're now moving into part of the session where we want to take questions. So let's start. We've had a couple in on patients. More comments, please, on how patient experience drive QI. And yeah, while QI can be a factor in bringing staff together, it isn't the missing part, often not involving patients and users. So, Jim, let me come to you first. A word on that, please.
As I explained earlier, we started really with patient experience in 2010, and we had a few goes at getting the measurement right and trying to work out how do you get it in a way that's captures the message appropriately, that's relevant to staff, etc. And it's just incredibly powerful. So if you do get that right, in that it's really relevant to the stuff that you're working with, patients have a way of cutting through on issues and just being really clear with very simple messages in a way that's just really hard to avoid. And it's, clinical staff are motivated around looking after their patients. So I think we can overcomplicate things at an organizational level in a way that patients can just be really direct about. Often they also include an improvement suggestion with it as well. So it's usually not just a criticism. It's you did this, maybe you do that next time kind of thing, so that you've got an automatic momentum. And then also I think the benefits and the power of staff receiving that, agreeing an action, measuring it, seeing improvement, etc. You just get momentum from that. So I think that's just really, really powerful. I'm immediately thinking of some really stubborn problems in teams where we just didn't think we could make progress at the beginning, and then the nervousness and what we're going to do, if it doesn't work, etc. And the patient experience stuff, I think, just really helped break through in a way that organisationally we would struggle to.
Really interesting. Something we often see in the projects that the Health Foundation funds is the power of patient stories and testimonies, often complementing. I mean, we saw the run chart earlier in your presentation, or the line graph, but how that will go so far, but actually hearing directly from service users can be so powerful in its own right. Elizabeth, any thoughts on this?
Yes, I just think those examples are incredibly powerful, aren't they? I can remember sitting with one of our shared governance councils. So all the members of the councils are band 6 or below, chaired by one of their members, but they would have they have a patient rep as part of that group as well. And they've all been trained in QI techniques. But it is that real honesty, isn't it, about having a patient rep there. And I can remember this example where we were talking about the difficulties of getting busy staff to kind of comply and make sure that they had got all their statutory and mandatory training done. And you just have to listen to a patient sitting there saying, I don't want to be treated by somebody who hasn't done their StatMan training. It really kind of sharpens the focus on why this matters in a way that I just can't imagine any other contributor being able to do that. So it is very, very powerful.
We've had a question from Carly Holiday, which says, any practical tips about how to get all board members behind this, particularly if they're not all enthusiasts? Any tips around that?
Sorry, can I go first, Elizabeth? Is that okay?
Just do.
So I remember the thing that immediately comes to mind is about 3 or 4 months I was appointed as chief exec. We decided as an exec team we're going to get really serious about quality and safety and improvement. And we had a board discussion, and I got summoned to talk to the NEDs and the chair and explain what I meant. And there's a lot of nervousness about it. So I was really surprised how nervous people were. Was it going to be inflationary? Would it distract us from our performance targets? Or we're going to open up things that we couldn't actually deal with, etc. And I think just the power of having open discussion about, what are we trying to do? Where do we want to be? What sort of things are we going to have to tackle, etc. And holding your nerve when things get tough. Everything doesn't automatically, just need to be dealt with overnight. You need a sense of priority, etc. So we spent a few months just kicking it around properly and getting under the concerns, how we get a plan together, what it actually might mean, what would it mean from a resource perspective, what it meant for execs as well, where would the exec focus be, and then start small, I think, and start showing little steps and bits of improvement. And the bit that originally in the first few years really got us off the ground was we were used to being in the bottom quartile on the staff survey, and nobody believed we could change it. Nobody in the boardroom believed we could change it. And, do really well in our staff survey now. It took 3 or 4 years of just relentless measurement, discussion, action, measurement, discussion, action, etc., etc. once you start getting the results, you get the momentum, and you start seeing things that work and it's worthwhile, and you get the power unleashed.
Elizabeth, anything to add?
Yes. So yes, it's interesting, isn't it? I think about it, and I think it was not that we had any board members that were not really behind it. I think the difficulty that we grappled with was people understanding what it was. I think everybody got a kind of slightly different interpretation of what we were talking about. So the board development programme that we did, where we had 4 different sessions over a number of months, really helped us could sort of explore and understand those ideas. And we had, it's interesting, isn't it, where support comes from, but across our non-execs, it was actually a former finance director and the chair of our finance committee who was probably the most vocal and most supportive. So it's not always the quarters that you think that it will come from, that where the support and the challenge comes from. I think the other thing as well is that sense of you're right, it is understanding that this is going to take a long time and that we do have to have long-term commitment, and that you won't see immediate results, but actually it is starting with the quick wins, because people do need to see a bit of progress, and also making it visible. So one of the tools that we had was we set up a newsletter really early on where we could just promote improvement stories. And I think it helped everybody realise that actually there was an awful lot of good stuff going on. Everyone knew locally what was happening, but I think for the board, they didn't really have the kind of sense of breadth and depth of the work that was underway. So it's a sort of small initiatives like that that really make the work visible and more understandable, and people can get behind it.
Something that we're excited about the board support offer that NHS Providers is launching is precisely because it might help board members maybe who don't know so much about it to find out more about quality improvement and how trusts get involved. Something, just reflecting back on Health Foundation research that has always struck us is when you listen to someone at a trust that's well advanced with its improvement approach talk about how it started, it was very often with a visit somewhere else where they thought, oh, stuff can happen differently. And one of the elements of this program NHS Providers is launching is a kind of virtual visits program. So we're hoping that that's going to provide a bit of inspiration and encouragement for that as well. A question from Julie Jarman. She asks, how do QI processes, governance, staff integrate with operational delivery? What are the challenges of that? Jim, do you kick us off?
We work really hard at trying to keep all of these things together. And I think there's a real danger and a risk to say there's some people over there dealing with the money and performance and staffing problems, etc. And it sounds, we all say this and it sounds really twee, but we work incredibly hard at trying to keep all of it together because they're all absolutely linked. So again, just thinking about examples, we've used for a while the big room thing out of Sheffield, which works really well. And one of the benefits of that is you've got everybody who's involved and relevant in the discussion is in the room, and you're not differentiating how the governance works differently from the performance or the money or the staff experience, etc. It's all dealt with in the round. So I think what I would say on that is just try and have a really fully integrated approach that's also proportionate to the task in hand. So from a governance perspective, don't kill it with bureaucracy, don't kill it with meetings and overhead and process. If it's a quick light process, it's a quick light process. If it's something that you think is going to take 2 years, set your stall out to be able to cope with 2 years and be able to maintain energy over that period, etc. But the key point, I think, is to try and keep it as integrated and as joined up and as connected as is humanly possible.
Thank you. Elizabeth.
Yeah, so just building on that, I think for us the trick really has been to have our divisional management teams, as I say, so that's kind of broad spread of people who are within those teams, and to have QI integrated there so that everybody is part of understanding what the priorities are locally, and also recognizing that QI is not going to be involved in all of the initiatives. Some things it works and others it doesn't. But I think the other thing is that we're looking at our kind of trust-wide business planning processes this year and really distilling a couple of key priorities to say these are the 2 kind of big things that we need to work on this year. but then not be prescriptive about how do we address those, because I think that's the trick for us. Culturally, one of the reasons that we really struggled and why that journey is so long, it is a 10-year timeline, is that we are very much a kind of can-do trust, but quite directive from the centre, and so haven't really allowed teams the freedom and the flexibility to come up with solutions of their own. And so having that kind of QI support and resourcing available locally helps teams to see, okay, well, if those are the priorities, then this is how we're going to tackle them. But it's not some kind of extra QI project that's tacked on to the end of a day job. It is the job.
Really interesting. I mean, listening to your presentation, Elizabeth, I was interested in the timeline where you initially had a kind of training program in place, but it sounded like then you subsequently decided you needed a refresh and a reboot. Something, is it fair to say, we sometimes see with improvement is people go on training, but then that training's not brought back and actioned. It doesn't become something real in their job. Yeah. Any tips on that?
Well, I think the really critical thing for us was we actually just amassed a huge amount of evidence around this about what the size of the problem. So in the first round of training that we had in the early sort of 5 years, what we ended up with was people, and somebody actually did a master's, their kind of master's thesis was about following up these people who'd been on the training, and they all just said, practically 100% of them, I did the training, I absolutely loved it, but I went back to work and either what I'd learned was not valued, or I wasn't given any time to do the work that I want, the priority project that I wanted to work on. The second round of training, when we trained all of our leaders and senior managers, they all just said, oh, well, this is really interesting and we think it's a great idea, but actually we just don't have any time for it. There isn't enough time in the day job. And it's the kind of counterpoint to the question that we've just answered, is that unless it is part of the day job, it's never going to happen, is it? But I think that was the cultural issue that we had, was that we hadn't seen that actually this kind of incremental improvement and allowing staff to find their own solutions to problems was the way to improve our performance. And I think quite often with sort of my personal view is that good trusts that are performing really well often struggle at thinking about those skills that are going to take them to the next level, because actually they're different. You need a different mindset, and you need to be able to encourage that innovation and freeing people up to allow them to be creative in a way you can get to good by kind of following the process, really.
Fascinating, thank you. Let me encourage people to keep the Q&A coming in. It's great to get some. We've got another one here from Geeta Patel about QI tools. She says, do the standard QI tools apply in dynamic situations where there's a mix of services, professional boundaries, population level interventions on the horizon? So complex landscape now, ever changing. What's that mean for the kind of tools we're deploying?
I think my observation here is that having that kind of a really core discipline about taking baseline data and then working out what it is that's going to improve, and then going through those cycles of change and testing out what works and what doesn't, is actually very flexible. It sounds rigid, but it can be applied in so many different situations. So the idea of working with a multidisciplinary team in circumstances where you're trying to integrate in quite mechanistic situations, or we've used it very effectively with teams trying to improve the way that they work together, very soft situations about relationships. All of those things have worked. I think probably, and I think Jim kind of alluded to it at the beginning, is the bit to watch out for is not getting people tripped up by the language and this sort of very prescriptive discipline that just puts people off. And I think that's part of it. It's how you shape those tools so that they are attractive is actually critical.
Jim, could I bring you in?
Yeah, I would just to add to that, I agree with what Elizabeth said, and I think just there's lots of tools, and just give some thought as to what the best tool is for the problem in hand. So again, I remember watching an RPIW many years ago, 15 years ago, with dozens and dozens of people involved, and totting up the cost of the event and thinking what a waste of money it was. Actually, there was this very small subset of people in the room could have sorted it out and wanted to sort it out in a very small part of the amount of time that was involved. So I think it's very, very much worthwhile thinking about, having a box with lots of tools in, but really thinking about, is this an issue that requires lots of data and measurement? Is it a big engagement thing, an RPIW type thing? Is it a psychology process, etc. So don't expect to use the same tool in every circumstance, because you'll just hit a wall very quickly.
Thank you. So in a moment, I'm going to keep the questions coming. I want to ask everyone listening, because NHS providers would like to hear from you. What would most help you and your organisation take the next step on your improvement journey? If you've got thoughts on that, even if it's not a question, put them in the Q&A. What would most help you take that next step? Jim and Elizabeth, I want to come back and ask you about the COVID context to all of this, which you talked about in your presentations. I mean, obviously it had a huge impact, not just on what was going on in trust, but I guess the strategy and the thinking about improvement within trusts. I think as we look ahead now, what do you think the challenges are going to be about sustaining some of the progress you've made during the pandemic, whether it's particular performance areas, whether it's things like internal communications, digital communications that you talked about, Elizabeth? Think about the progress that's been made during this time in this very particular context with pressures and a sense of common purpose, and what's going to be the challenge in sustaining that going forwards?
We've got lots of challenges, haven't we? It's going to be a tricky 5 years or so ahead of us, and I think we're all struggling probably with the power of the pull to return to normal, whether that's volume, people presenting who weren't presenting before, getting rid of backlogs, all those sorts of things, and the system closing in as well to behave more pre-March of last year. So we've got to try and really hang on to the agility and the focus and the clarity that was created. We moved as everybody did, loads of services around over 2 days. And we're really liberated from a lot of the central guidance, control, over silo, over professionalization, etc. All the things that had been barriers for years. There's actually a really strange feeling of liberation at the beginning of COVID. And you can feel that being diluted over time as everybody tries to get back to normal. So I think the ability to stay agile, stay free, stay loose and flexible as we move into a very complicated period that is still, it's going to take a bit of navigating. I think that's one of the key things. And also maintaining energy and motivation with a tired workforce. It's right that we talk about it all the time, but there is also a risk that we make it worse by talking about it so much, and people need to get up and rested. And I just think we've got various not waves of COVID, hopefully, but lots of waves of finding new things that we've got to deal with, whether that's a cohort of patients who start to present who weren't presenting before, retirements. We were all aware of people wanting to retire, some shift in a clinical model, interface issues with other parts of the system, etc. So we've got to, if we hang on to one thing, it's that agility and the feeling of being liberated to deal with the task in hand rather than constrained.
It's really interesting to hear. I mean, obviously the centre of the NHS played an important role in dealing with COVID, but it's what we've heard elsewhere that actually the inability to micromanage things during the crisis and the letting go involved in that has created the autonomy that's made a lot of important progress happen. And it's a very powerful message, Jim, including for people at the top. How can we retain the goodness of that under new pressures as we go forward, or will the old control instincts reassert themselves? Elizabeth, any thoughts about sustaining progress during COVID, or just the challenges looking ahead?
Yeah, I mean, I think there are some positive signs as well, and I agree with all the things that have been said so far. And particularly it's that kind of the dead weight of bureaucracy that I think we all don't want to see return in the way that it was before. But I think for me, I have already talked about digital, and I think there are huge opportunities in there, though it does need to be managed. It's not all positive. I think there are some other things, though, that are energising. I personally am very pleased to see that focus on the health and well-being of staff so high up in our planning guidance, and I think that helps. So just as Jim started off the presentation with that very, very close monitoring of how is it that our staff feel, I think there is much more emphasis on that top to bottom across the NHS than I've ever seen before. And again, in terms of collaborative working, the collaborative working across the North West London system has opened up a lot of support for our staff that has never been there before. And it makes much more sense that we do that on a system basis than within each trust. So I think that's very important. I think the other thing is that the emphasis which we're seeing on inequalities and population health is very motivating for our staff as well. So I think they see there are opportunities, both in terms of improvement science and QI supporting them locally to solve those local problems and irritants that they want to see addressed. But actually, we've also got a huge amount of work going on that really resonates with the kind of ethics and values about why people came into the NHS. So there are other pointers that I think are positive to be a counterweight possibly to the bureaucracy.
That's really encouraging to hear. So it sounds like, I mean, certainly COVID exposed a lot of inequalities issues, and there was a hope from it that one legacy of that would be more focus and action there. It sounds from what you're saying, Elizabeth, that actually is a reality, that there is more emphasis on it and action. Is that fair?
Yes, absolutely. So I think, within my own trust, we've got groups of staff and doing lots of analysis on data about access to services and how that's been impacted different groups. And it's a geographic analysis as well as by, different ethnic characteristics or age groups and so forth. There's lots of different ways of cutting that data, but it's getting us to really start to look in a very different way, not only about the services that we're providing and how that might be unequal, but also for staff to kind of question a lot of the assumptions that they've made about who is and isn't being referred, who's actually turning up or isn't, and what that is meaning in terms of the longer term health inequalities, and therefore, the drain further down on, particularly on the acute system.
Really interesting. I'm going to now come to our panelists for a final comment each, a takeaway thought each. Jim, perhaps you could make yours in the context of the final question we've had. It says, Elizabeth reflected how the Health Foundation report helped them realise the steps they'd initially missed. Is there anything Jim wishes he'd known at the start that he's learned along the way? So perhaps in giving us a takeaway thought, you could answer that too.
I wish I'd understood how important the language was and how strongly people would feel to the point where you could turn them off because they felt really strongly about a specific model. I remember having an argument about a definition of quality 10 years ago, thinking, why am I having this argument? This just feels really weird. But people feel very strongly about those sort of definitions, the methodologies that are used, whether one works better than another. And that took time to resolve. And also from our perspective, it felt like it took us a very, very long time to get over the fact that our model wasn't a very distinct Six Sigma, Seattle, whatever, the very established approaches. It was a looser model. It was more complicated. And that's our model. We had to work out how we describe that. And honestly, I think we wasted 5 years arguing about that. So I wish I'd known at the beginning that was fine. It doesn't matter as long as you're improving. I had a discussion with a colleague yesterday who said, it just started here, and he's in an innovation role. And we had a discussion about if things get better, it doesn't matter if we call it innovation or transformation or improvement or whatever. It's just got to get better. And again, I wish I'd known that at the beginning. We could have saved a lot of time.
Thank you. Wise advice. Elizabeth, over to you.
It's very interesting, actually. As I say, it was the bits that were unspoken and the problems with the culture that I think really did take me by surprise. And again, I'm very happy to say, we ended up in a cul-de-sac where, frankly, we were applying our very skilled QI staff to helping us, sending them off to teams that had actually got a problem where we were saying, you guys need to save some money. Can the QI team go in and help them understand how they might do that by making them more efficient? Well, we weren't ever going to win the day on that one, were we? So we weren't going to get the buy-in. So I think that's why in my presentation, it is, if you don't have that buy-in and that sort of sense of a social movement and people wanting to join and be part of it, I think it does make it so much more difficult. So it's very interesting to see, you know, we all have those cul-de-sacs along the way for different reasons.
Thank you. Well, our time is nearly up, so I'm going to draw the session to a close. It's been a real privilege hearing about your experiences and having you here to present to us. So first of all, a big thank you, Sir Jim and Elizabeth, for joining us today. Thanks also to NHS providers for making this session possible. At the Health Foundation, we're really excited to be working, as I said, with NHS providers on this new board support programme, which we hope can really help more trusts take some steps along this improvement journey. Historically, there's been a lot of spotlight, and rightly so, on some of the leading improvement trusts, but there are many more earlier on that journey, and helping more trusts begin to put in place organisation-wide approaches to improvement is really important. I think COVID, certainly our research shows, COVID really exposed the importance of that, where trusts that made investments a few years ago and had well-developed improvement approaches found themselves able to respond in certain ways better and struggled less than those that hadn't. So we've got high hope for this programme. We're delighted to be partnering with NHS providers on it. Finally, to say thank you to everyone who's joined us today to listen, and for the conference as a whole. It's sad it's now coming to an end, but I hope you've enjoyed the session. Do stay in touch with the programme through NHS providers, and very best wishes. Thank you.